Welcome back to our Community Medicine Revision series. Quickly, before we start, please subscribe to the channel, like this episode and drop your next topic request in the comments. Your suggestions shape our syllabus. Today's focus is intrauterine devices, especially copper T, plus an overview of contraceptive classification, the Pearl Index and the Cafeteria choice approach. Dr. Joshi, shall we start with the big picture? How do we classify contraceptives in a way examiners like?
For exams, keep a clean scaffold. 1. Natural methods, which are periodic abstinence, cervical mucus method, basal body temperature, the standard days method, and lactational amenorrhea method. 2. Barrier methods, which constitute male and female condoms, diaphragm with spermicide, cervical cap, and spermicidal foams or gels. 3. Hormonal methods, namely combined oral contraceptive pill, progestin-only pill, injectables such as depo-medroxyprogesterone acetate DMPA, subdermal implants, transdermal patch and vaginal ring. 4. Intrauterine devices IUDs, which include copper-bearing devices and levonorgestrel releasing intrauterine system. 5. Permanent methods, which are male sterilization, vasectomy, and female sterilization, tubal ligation. 6. Emergency contraception, for example, levonorgestrel pills, ulipristal acetate, and the copper IUD used postcoitally. Finally, some texts list traditional or local methods separately.
Great. Quick exam warm-up. What is the Pearl Index and what are its pitfalls?
The Pearl Index expresses effectiveness as the number of pregnancies per 100 woman years of exposure. Formula-wise, pregnancies multiplied by 1200 divided by total months of exposure. It is simple and popular but has pitfalls. Short studies can exaggerate failure. It mixes perfect use and typical use unless specified, and it does not account for discontinuation over time. Life tables or survival analysis gives a truer time-specific picture.
Now, the Cafeteria choice approach sounds tasty, but what does it mean in family planning?
It means informed, client-led choice. Like a cafeteria menu, the provider offers the full range of methods with unbiased counseling, explains benefits, risks, side effects, and when to return, then respects the person's choice. It emphasizes privacy, non-coercion, and eligibility screening using the WHO medical eligibility criteria. It improves satisfaction, continuation, and method fit with lifestyle and medical history.
Perfect. Let's dive into intrauterine devices, especially copper T, since they are favorites in vivas. First, mechanism and types.
Mechanism first. Copper-bearing IUDs act primarily before fertilization, where copper ions create a local inflammatory and spermicidal environment in the uterus and tubes, impairing sperm motility, viability, and capacitation. They also alter tubal transport. Implantation, if it were to occur, is also unfavorable, but the main effect is anti-fertilization. Types are A. Copper IUDs, for example CU-T380A, T-shaped, surface area about 380 mm, CU-375 variants. B. Levonorgestrel releasing intrauterine system, which thickens cervical mucus and suppresses endometrium. That is excellent for menorrhagia, but today we'll keep our spotlight on copper T.
How effective is copper T in numbers that students can safely write?
With typical use, COT380A has a failure rate around 0.6 to 0.8 pregnancies per 100 woman years of exposure. And with correct insertion and retention, it is among the most effective reversible methods. Duration of protection is up to 10 years for 380A. Some programs label 5 to 10 years. Quoting up to 10 years is safe for exams. CU375 variants are typically up to 5 years.
Candidate-friendly question. Who is a good candidate and when can we insert it?
Who? Any person seeking long-acting reversible contraception who is not pregnant, has no current pelvic infection, and has a uterine cavity suitable for placement. Nulliparity is not a contraindication. When? Any day you are reasonably certain the person is not pregnant, day 1 to day 7 of the cycle is convenient, post-placental, within 10 minutes of placental delivery, within 48 hours postpartum or after 4 weeks postpartum, post-abortion immediately if no sepsis. For emergency contraception, insert within 5 days of unprotected intercourse.
And the key contraindications we should not miss?
Absolute ones are known or suspected pregnancy, current pelvic inflammatory disease, purulent cervicitis or active sexually transmitted infection, unexplained abnormal uterine bleeding pending evaluation, postpartum or post-abortion sepsis, current cervical or endometrial cancer, distorted uterine cavity, known copper allergy or Wilson's disease. Relative ones are high ongoing risk of sexually transmitted infection, severe anemia with heavy menses, very large fibroids not distorting cavity, and certain cardiac conditions needing endocarditis precautions.
Side effects and complications and how to counsel?
Expect heavier or longer periods and more cramps in the first few cycles with copper devices, often settled by 3 to 6 months. Expulsion occurs in roughly 2 to 10% in the first year, highest early and in immediate postpartum placements. Perforation is rare, about 1 per 1,000 insertions, and usually at insertion. Pelvic infection risk is very low after the first 20 days post-insertion. The IUD does not cause infection, but pre-existing infection introduced at insertion can flare up. Hence, screening for symptoms and syndromic management is key. Ectopic pregnancy overall is reduced because pregnancies are rare. However, if pregnancy occurs with an IUD in situ, the proportion that are ectopic is higher, so rule it out. Counseling points would cover effectiveness and duration, expected bleeding pattern, how to check strings, no protection against HIV or other sexually transmitted diseases, where we offer condoms for dual protection. Warning signs using PAINS, period late or abnormal, abdominal pain or pain with intercourse, infection signs, fever, discharge, not feeling well, systemic, strings missing or shorter or longer. Pause and recall, what is the early window of slightly higher pelvic infection risk? Answer, first 20 days.
Could you walk us through the follow-up in brief, the way an examiner might expect?
After insertion, observe briefly for vasovagal symptoms, advise what to expect, when to return, and how to check strings. Follow up at 4 to 6 weeks, then annually or earlier if problems. If strings are not felt, exclude pregnancy, do a pelvic exam. If not found, perform an ultrasound. If device is intrauterine with no symptoms, you may leave it and teach other follow-up methods or remove and replace if desired.
Let us practice with a vignette. Case 1. A 24-year-old, one living child, presents at 6 weeks postpartum, exclusively breastfeeding, one spacing for 3 to 5 years, no history of pelvic infection. What would you offer?
Use the cafeteria approach. Offer long-acting options. COT380A at 6 weeks postpartum is appropriate. Also discuss levonorgestrel intrauterine system, the 3-monthly DMP injection, and the implant. Since she wants 3 to 5 years, COT380A fits well, is hormone-free, does not affect lactation, and is highly effective. Screen for contraindications, counsel about bleeding changes and PAINS that we discussed earlier, and insert.
And how do we manage common problems, say increased bleeding after a copper IUD?
First, exclude pregnancy, infection, or partial expulsion. If none, reassure that it often settles. Short courses of NSAIDs during menses reduce prostaglandin-mediated bleeding and cramps. If unacceptable, consider switching to a levonorgestrel intrauterine system or another method per preference.
Before we wrap, could you tie back IUDs to the Pearl Index and Cafeteria choice so students can integrate concepts?
Certainly. Pearl Index helps you compare methods quickly. Copper T's the index is well under 1, signaling high effectiveness. But remember its limitations. Quote it alongside real-world counseling about continuation and side effects. Cafeteria choice is your operating philosophy. You present copper tea as one strong item on the menu, not the only dish. You check eligibility, explain mechanisms, side effects, return signs, and let the person choose. That respect for autonomy improves uptake and long-term satisfaction.
Final exam pad summary please, Dr. Joshi. 30 seconds.
Classification is natural, barrier, hormonal, intrauterine, permanent, emergency. Pearl Index is pregnancies per 100 woman years, useful but limited, supplement with live table data. In copper tea, anti-fertilization via copper ions, COT380A up to 10 years, effective, reversible, hormone-free. Insert when reasonably certain not pregnant, postpartum immediate within 48 hours or after 4 weeks postpartum, post-abortion immediately if no sepsis. Contraindications are pregnancy, active infection, unexplained bleeding, genital cancers, distorted uterine cavity, copper allergy, or Wilson's disease. Side effects are heavier periods, cramps, rare perforation, early insertion-related infection risk. Counseling points are strings, PAINS, dual protection for HIV or other sexually transmitted diseases, follow-up. Cafeteria choice offers full range, ensure informed voluntary selection.
That is a neat exam-ready package. Pause and recall. List the 5 absolute contraindications to copper tea you'd write in the answer book. Thanks, Dr. Joshi, and thanks to everyone revising with us. Catch you next time.